evening, everybody, and welcome to DocTalks. I'm Kent Lewis. I'm the Director of the Forensic Mental Health Program at St. Joseph's Healthcare at London. It is a pleasure to be joining you this evening for Dr. Forchuk's presentation, Playing Musical Chairs, Understanding the Problem and Solutions Related to Homelessness. I recently met Dr. Forchuk at a mental health research meeting in Toronto. It was a pleasure to meet her in person, and it was very evident from her contributions in the meeting that she has an extensive knowledge of many aspects of mental health and homelessness. I have followed Dr. Forchuk's research over several years, and her research contributions have significantly paved the way for better mental health care. For those of you who are attending DocTalks for the first time this evening, welcome. I know you're going to find this evening's presentation both informative and very thoughtful. For our regular attendees, welcome back. We are so pleased that you continue to join us for these truly remarkable lectures. I know that many of you in our audience this evening are donors to St. Joseph's, and I'd like to share my personal thanks to you for your kindness and your generosity. It is through your commitments and support that St. Joseph's is able to invest in specialized care and research for you, your families, and our broader community. Thank you. The 2024-25 DocTalk lecture series have been sponsored by Chartwell Retirement Residences, so I'd like to give them a huge thank you for their support. Chartwell is Canada's leader in senior housing. Their focus is people and supporting health, happiness, and peace of mind for older adults, their families, and the communities across the country. Through their many diverse residences, they offer flexible care and support options to meet the needs of older adults. Thank you again for your sponsorship. We are most grateful. Tonight, we are very pleased to have Dr. Cheryl Forchuk joining us as our presenter. Before we dive into this presentation, I'd like to share a bit more about Dr. Forchuk. She is a distinguished professor at Western University, a scientist, the interim scientific director for Parkwood Institute Research at St. Joseph's, and assistant director of Lawson Health Research Institute. Her work interests lie in the area of mental health, in particular, the development and testing of supportive models of care. Her research explores therapeutic relationships and system issues related to mental health care, including implementation of the transitional discharge model, housing and homelessness issues, poverty, community integration, and the use of technology in mental health. This evening, she will be presenting Playing Musical Chairs, Understanding the Problem and Solutions Related to Homelessness. Ladies and gentlemen, please join me in welcoming Dr. Cheryl Forchuk.
So thank you so much, Kent, and I'm hoping that I can count on the audience. Similarly, if you can't hear, let me know. I got all this stuff. Okay, so this is the topic, and what I'm going to be covering today is I'm giving you an advance warning in case somebody nods off partway through and what was she going to be talking about. So some people talk about homelessness as one of those wicked problems. We can't possibly solve it. It's always been with us. I'm going to show you that it is a solvable problem. For one, I'll be talking about it. It's not an easy problem to solve. It's not a cheap problem to solve. But I'm going to give you a model, and this model will also help you when somebody's saying they're doing something to address homelessness or reduce homelessness. I'll give you the right questions to ask, and we'll come back to that. The other thing, though, I want you, because we're here as part of St. Joseph's. So the other thing I want to talk about, and my background, as you can see, I'm a nurse. I'm a registered nurse. The reason I went back for a PhD after working for many years in practice as an advanced practice nurse, and in that role, it was always about trying to help staff when the usual care didn't work, when there was something unusual. So how do we tweak the system to make it work for this particular person. And after many years of doing that, it's like, at what point do we decide, you know what, it's actually the system that needs to change? And so the reason I went, and you'll see most of the research I do, it is about larger systems areas, models of care. The reason I got into homelessness was almost 30 years ago, I hate to tell you, about to an anniversary, I was noticing the increased risk of people that we had been working with on other projects for homelessness. And when I worked in, this is the risk of having been around a really long time, because I actually remember when we did not have a homeless problem. So when I worked previously in direct care, if we discharged someone to homelessness, it was the same incident report as a patient assault that we had to fill out. That's how rare it was. And I remember the 1 year, we had 2 in 1 year, and we had a big meeting. We called everybody together, like, how could this possibly have happened? Flash forward a few years later, I'm doing a project with the transitional discharge model. I got 6 different hospitals throughout the province involved in the project. And across all 6 sites, some of the people we're seeing post-discharge are homeless. We're interviewing people in homeless shelters. What the heck happened? And when I would talk to the staff, how is it this person ended up homeless? Well, they don't have housing skills or they don't have whatever. And it's like, well, how is it possible across the entire province, simultaneously, all these patients lose their housing skills? That makes no sense. And so while I was pondering that, I don't know, do you ever have the situation where the universe is trying to give you a message, and if you don't take it, it slaps you again and gives you another message? So I was getting that first message, and I went, this is weird. This does not make sense. And I had recently started working here in London, although I was still doing this other study, which included London, included Hamilton, St. Thomas, a number of other places, Penetang, in terms of forensics. So I'm thinking, this is weird. I get a call from Mission Services at that point. They're saying, you got to do something about all these former psychiatric patients showing up at our door. We got a 1 to 50 staffing ratio. This is no place for someone to be. Well, yeah, that definitely is no place. And then within the same month, I got a call from Lifespin, which is an anti-poverty group, about the women that they were seeing. Same thing. They were coming from psychiatric. And just in case I didn't yet get the message, the very same month, that this was so long ago, my son, who's now in his early 40s, was still in high school, and he was very interested in art, and he had a friend very interested in art that would come over. So it was at my house many times. That friend's, that family became homeless. The mother had schizophrenia. The father had killed himself. She became psychotic. This 15-year-old ended up homeless. Actually ended up quite often, he basically ended up in my basement for a period of time rather than being homeless. So with all these messages, I thought I better take a close look. So I called together the community agencies that I was talking to in the what the heck is going on? There's obviously something else going on and that we don't understand. And that's part of where we came up with this homelessness and this model around musical chairs. So we will come to that. But before we move to the next one, I do want to thank the foundation for hosting these events and bringing these issues forward to the public. And the foundation's always been very strong. There's been many times I've called the foundation for help for things. And so very happy to help the foundation by speaking today. I'll just do quick examples. When we had one of our smart technology projects for vulnerable youth, these were mostly homeless youth, and we had given them a phone, and the study was going to be ending just at the beginning of a pandemic, and we did not want to disconnect those phones. For those kids, that was a lifeline. Some of them were ending up going into isolation, etc. And the foundation stepped up so that we did not have to discontinue those phone lines. Just as a very practical example, it wasn't a lot, but it certainly meant a lot to those youth. Similarly, having just recently finished a research chair, and people say, well, what good's a research chair? Well, a normal faculty position, I get 2 days a week to do research. So you can see when you see some of the research, how hard that might be if you were only allotted 2 days a week for really big problems. So do support the foundation. It does make a difference. So as I say, so the second thing, as I said, after we get through that model, as I said, I'm also going to be talking about why homelessness is a health issue, and I'm going to be giving you some concrete examples of where we're trying to really grow the evidence. Now, I always feel weird when it's just me standing here. Picture a whole pile of people behind me, because I never do research alone. Research is a team sport, and particularly the kind of research I do, it involves participatory action. So there's multiple people, not just the research participants, but people with lived experience. If you look at some of our papers, particularly the books we've published, you'll see people with lived experience are co-authors on many of those chapters, but also frontline staff, community partners, students, our co-investigators, and my research staff. So although I'm standing, do not think for a moment that this is something I just do myself. It's very much a team thing. And I'm just incredibly lucky for all those groups that help us constantly. So I don't want to take a long time on this one, but I'm going to have at least 3 people tell me, what does having a home mean to you? When you get home and you walk through that door and you're home, what does that represent to you? Three people anyway. Yes. Safety. Yeah. Like how many people, they get through that door and it's almost like you can exhale, right? Like, I'm here, I'm safe. What else? Yes. Security. Was that the same thing over here? Yeah, security. Again, it's part of that idea of safety. You can lock the door, right? What? Comfort? Yeah. The familiarity. What were you going to say? Yeah. You've got people in that environment. I want you to think about all the things that are in your home. The people, for sure, are part of what's in the home. Think of the memories that are in your home, the pictures, the photo album, the things on the fridge, the fact that you have a fridge, right? You have a bathroom that you can use. You may have your grandmother's dishes. I have my grandmother's dishes. Different things that link you to the past and who you are. Pets, right? So when you think about what does it mean to lose a home, it's so much more than simply not having a roof over your head, because you lose all of that. You very often can no longer have your pets. In fact, some people will avoid going to shelters just to try to hold on to their pets. You lose those dishes. You lose the photos. You lose that sense of safety, but you also even lose access to a private bathroom, to a shower, that where it's not on a timer or whatever, where people aren't knocking on the door. So think of all those things, because trauma is very much interlaced with homelessness. There's often prior trauma, but even if there's not, it's traumatic to lose everything in that way. Like, if you think of yourself, what would it be like to lose all those things? I think you'd have to agree that would be incredibly traumatic, right? So how do we understand such a complex thing? Oh, wait, I did already answer that question. Have we always had that problem? I already gave you that example. No, we did not. In fact, I always meet, particularly with our psychiatry residents, when I try to put the fear of God into them to not discharge into homelessness. And one of the things that often surprises this younger group is when I say that very same story, that it used to be as rare as a patient assault, rare, even more rare, because we become, it's like the frog in the boiling water. We just become acclimatized to it, and we think, oh, this is how it is. No, it's not how it is. So I'm going to give you the analogy of the musical chairs. If you can understand musical chairs, you can understand homelessness. Everybody's seen the game? Everybody played the game? Okay. So I want you to think of the chairs representing the available, affordable housing within a community. Now, there's many definitions out there on what's affordable. So if you look at Canada Mortgage and Housing Corporation, for example, they will talk about that affordability, that you're not spending more than 30% of your total income on housing. But you know what? That kind of blurs things a bit, because I think there'd be a difference for somebody who makes $10,000 a year versus someone making $100,000 a year if they're spending that big chunk. It really kind of blurs over the issue of poverty, like how much income do you have? So when I'm saying this, I'm talking about people who are in poverty. What if you're on Ontario Works? And I'm going to show you some numbers in a few minutes as to how much money that is. Or on Ontario Disability Insurance, or on old age security. What housing is there available for you at that income level, right? Because that's the true test of affordable, not if somebody with $100,000 is spending more than 30% of their income. But that technically, according to that definition, would mean you're in core housing need. I don't think you're in core housing need. You've got to spare 700, yeah, right, whatever, 70. So the people circling are the people who are at that income level. So the people who are on ODSP, OW, old age security, etc. So it's pretty clear. This is not rocket science. If you got more people circling than the chairs, guess what? Right? Does that not make sense? So no matter what other complicated thing you can come up with, you either got to, and I'm going to repeat this several times, you got to either reduce the people circling or you got to increase the chairs, right? Otherwise, you're not going to impact homelessness. The other thing about this model, a big part of the game is the music, right? The music stops. That's when you're vulnerable to getting kicked out of the game, or in this case, becoming homeless. I want you to think of the music. What is music but transitions, right? And there are periods where transitions are where you're more likely to lose your chair, because you got to be kind of moving between things when you lose the chair. If you're just sitting in your chair, you're not losing the chair. It's when you get up and you move. So what are the transitions? And these are periods of vulnerability. Unfortunately, leaving hospital can be one of those periods. But in London, I would say we've really shone the way in that. We've done a lot of good models and good evidence, and finally other people are looking to it, other places, to look at preventing discharge to homelessness, relationship breakups, retirement, losing a job, aging out of children's aid, coming out of the judicial system or jail, sometimes even interactions with the judicial system. So there's many different times when the music could stop. So you could have prevention programs that target that. So like, for example, programs to assist youth aging out of children's aid, or programs to prevent discharge to homelessness. But if you don't deal with the people circling in the chairs, you're still going to have homelessness. So on the other hand, when you prevent someone from getting homeless, that's ideal, because the longer someone's homeless, the harder it is to get out, because it's not just about it's always about the chair, it's always about housing, but it's never only about housing. And the longer someone has been homeless, the harder it is and the more support they need to get back and into feeling comfortable. I've worked with some of our projects where we've had people who've been chronically homeless, in many cases a decade or more. And it often takes them a year with regular support to feel settled. When they first get a place, they're sleeping under the bed, in a closet, on the balcony, just trying to get used to it. They've got their knapsack always packed right at the door in case it falls through. They won't put a picture on the wall, and sometimes they're afraid to get good stuff because of that fear of losing it all over again. So the longer someone's been homeless, the harder the adjustment back to being housed. So prevention is still a very, very good thing, but you still have to deal with these other things. So what's happened to the chairs? So we've gone through in Canada, and this is why I was seeing this earlier on, through a series of downloading. A lot of the responsibility, particularly for things such as public housing, as well as homelessness, used to be at the federal level. And indeed, in every other industrialized nation in the world, it happens to be at the federal level. So it was downloaded right around the time I was noticing, what's going on here? So it was downloaded to the provincial level. And the provinces didn't really want it, because it's just like your own budget. Housing is one of the biggest things. And it's the same thing when it comes to the cost of providing public housing. It's expensive, right? It's expensive. So what happened was the provinces were canceling contracts left, right, and center, and not building new housing because they didn't want it. And then in Ontario, we thought, well, that's a terrible idea. I wonder how we could make that one worse. So in Ontario, they downloaded it to the municipal level. So from those of you who've been around as long as I have, or longer, a building that used to say Canada Housing became Ontario Housing and is now London Middlesex Housing, right? But it was the same thing when it went to the municipalities. The municipalities didn't want it. And by the way, we now suspect half the homeless people in the country are in Ontario. So this is what, again, it's very much about policy, right? And anyway, so you can imagine, and we never had a glut of public housing. When you compare us to most European countries, for example. But this really dried up the stock. And it's not that you have to be constantly building new stock. One, because the population is growing. But the other reason, buildings don't last forever. So in some of those years, there were more buildings that were no longer usable than new housing being created at the same time. As this series of downloading. And again, only industrialized nation in the world that does this. The other thing Ontario did, just to make a bad thing really bad, when they downloaded to the municipalities, they also gave the municipalities the option to opt out. You know what, if you don't want to do anything, that's okay. We don't have poor people. And any clue as to which municipalities might decide to opt out entirely? No, London did not opt out. No. Any other? No, Toronto, the large urban centers could not possibly opt out. Nope, they couldn't opt out. It was the small rural communities. Where when you think of it, in the small rural communities, there's a much greater emphasis on home ownership, right? In a lot of these communities, there's not much rental property at all. So then you take those places, and then there's also no public housing and very little rental housing, which created all kinds of other problems in terms of migration from those communities. But again, it's like, oh, well, we don't have poor people here. We don't have a problem. So that's what was kind of going on with the chairs. So because of my interest in mental health, I will just say with having a perfect storm, this happened at the same time as so-called deinstitutionalization. I have nothing against deinstitutionalization. It was a wonderful thing that we had new medications available, new treatments available, that people could now not have the same lengthy stays in hospital. So it was evolving for decades. We could ask ourselves, was it deinstitutionalization or dehospitalization? That'll be another talk. We ended up with like 20 planning documents in 20 years. But back in 1960, we had almost 20,000 psychiatric beds. And again, so it went down, to less than 2,000, et cetera. But in that period, we did not see the investment in community mental health, and we certainly did not see the investment in housing. And there's many things that a hospital, so if you're in hospital and you get your meals provided and a place to stay, et cetera, but the perfect storm was this happened at the same time as the decrease in public housing. And I don't think, and because we often are in our silos, and as I say, that's why I thought, what the heck, what's going on? Why are these people in homeless shelters? Well, it was because of that downloading happening at the same time we were trying to get people out of hospital. When you look at it that way, it's not even why did it happen? It's like, how could you expect any other outcome, right? Because when you're going to and it wasn't just Canada, the deinstitutionalization was going around the world. And when you're talking about things like mental illness, you're also dealing with stigma. So if you don't have public housing, you're relying on private landlords. Many studies have shown that people with mental illness are the most stigmatized, and I include addiction in there, most stigmatized group in society when it comes to things such as who do you want to hire, who do you want to rent to, who do you want your daughter to marry. Probably somebody with schizophrenia is not high on that list, even though they may, in fact, be great at all those things. So the people circling really represents, as I said, people living in poverty. And I will say at the same time it was the same omnibus bill in Ontario that downloaded housing also cut welfare payments, or what we call Ontario Works, by 25%. So in other words, let's increase the people circling, plus take away a bunch of chairs, and we're going to discharge a bunch of people from hospital all at the same time. Ontario Works, and I didn't check the last year. This might be slightly off, but I think it's still pretty close. People think people get rich on Ontario Works. There's two parts to Ontario Works. One is the shelter allowance, and the other is the basic needs. So this tells you for a single person, you're supposed to find a home, including all utilities, for $390 a month. Anybody know any place like that? Can you even rent a room for that price? And then when people can't do it, they say, well, it must be your budgeting skills, right? How does somebody do that? I put some of these other things in terms of family size, because one thing I get really tired of hearing is that people have extra kids on Ontario Works to somehow cash in on the bank. Now, I want you to do the math here and tell me how that's going to make you rich. So now you've got 6 people or more, which is the cap, and you get $844 with 6 people in the family to rent a place. Are you really cashing in some secret sauce thing? I don't know. And this is the basic needs portion. So it's the two things added together. So for everything else, like your clothes, your food, as a single person, and as you can imagine, many people end up having to use some of that to pay for the living accommodation, because the previous slide, that $390 is not going to cover it, but you only get another $343. So you're not going to get very far with that. And yet we blame the person for this. Like you can't budget, you don't know how to handle your money. I think there's almost nothing more insulting to someone at that income level than giving them a class on how to budget. They could probably give us classes on how to budget. In fact, that's what we did when we did it. When we were doing some of our projects, I would have people who knew where to find the day-old bread and where the meal programs were and everything, how to possibly make that work. So what can be done about it? Well, I'm going to go in a little bit more detail in a minute, but I think it's important to also think globally and to really be sure that you think of this as a systems failure rather than an individual failure. Because sometimes who's homeless and who's not is who is standing in front of the chair, right? But it doesn't mean we don't act locally. We act locally, but we still understand there is a broader systems issue. The solutions have to cross sectors because you can see it relates to the housing sector, the income support sector, as well as the health sector. So these are groups that don't always collaborate. Now, we've seen some wonderful examples in London where people are starting to collaborate, but because of crossing those sectors, you must collaborate. And you have to, one thing we can all do, we have to advocate for strategies that either increase the chairs or reduce the people circling. If it doesn't do one of those two things, and ideally both, it is not going to change the rate of homelessness. You could have a policy that says, for example, women fleeing, and this was a provincial policy, as an example, that women fleeing domestic violence get first access to the public housing. So that's fine. You'd say, okay, that doesn't change homelessness. That just says, who am I comfortable being homeless and who am I not comfortable being homeless? You're just choosing a homeless group, but you're not changing the total rate. So you have to be really cautious when you look at some of those strategies. Does that actually change homelessness? And that's what you're going to look for. Will it increase the chairs? Will it reduce the people circling? So just to give you examples, and there's many more examples than this, but for time, we have to increase our investment in public housing. And actually, London, compared to many places, has done a decent job with that. And there's other ways you can do it too. In some of our projects, for example, with our homeless veteran project, we had rent subsidies, which would give them a bit more money. And although, because once we got them there's so many resources available to veterans that ended up being fairly short term. We worked with homeless youth, and they really wanted to get out of the downtown core because of the proximity to the drug and sex trade when they were housed. And I remember at the same time we were giving $200 generally to the vets. And we were meeting with the youth, and they said, no, I want $50 a month. Because $50, if I get stable, I can make up $50. I'll never be able to make up $200. So we worked with the Sisters of St. Joseph's who had a program that they would give a gift, because we had Ontario Works also on the committee, and they said, you know what, like we don't have to claw back if the money comes from a religious organization. So again, when I tell you I have great community partners, we have great community partners. So going, okay, well, I work at St. Joseph's. We probably have some religious organizations hanging around. So for $600 a year for these youth, they were able to help those youth. And you know what? There were almost all of them only needed 12 months. There was a few that needed longer. Those are the ones that had kids themselves. And most of them, once we hit 18 months, they no longer needed that because they were able to get on their feet. And so, but many other examples around the chairs, bylaws as to how easy is it for a granny suite, how many floors up do you do, population density. There's many ways that different levels of government can look at in increasing the chairs. These are just a couple of examples. Basically, any anti-poverty strategy is a strategy to reduce the people circling. So anything that reduces poverty will work. We kind of had a basic income program that wasn't properly evaluated with CERB. It was the first time in decades that we actually saw a reduction in the poverty rate in the country. But it very much follows the idea of that $2,000 a month as a basic income. It's very similar to what other jurisdictions, other countries have done, which actually simplifies things, where instead of having to have all these different programs, they've actually found it reduces a lot of the administrative costs. Yeah? Could you just explain that acronym that you used, please? Sir, remember when people, during COVID, people who were, everybody was guaranteed at least $2,000 a month, CERB. And I can't remember Canada. I can't remember what it stands for. Does anybody remember? Yeah, but people got $2,000 a month. And also, we've done some of that prevention work. I won't go into all the details. And also this idea of housing first and harm reduction. You can't expect someone who is living on the street to get their act together so that they can earn the right to housing, because your focus is down to the minute when you're homeless. It's all about, where is my next meal coming from? Where am I going to sleep tonight? And who's that following me? Are they going to hurt me? Right? You're so focused on the moment. You can't expect someone, this would be a good time for you to give up alcohol, or this would be a good time for you to start going and applying for new jobs. Well, even though you don't have a phone and you have no address. So you really need to get housed first and then go on to those things. The other thing that we've studied in some of our work is social enterprises, which have been highly successful. We worked with Impact Junk, Goodwill, the program formerly at Regional Mental Health. Youth Opportunities Unlimited in London's an excellent example, runs a number of community enterprises. So it's the idea of having a business that specifically provides employment for people to then transition in, but it's a livable wage and allows them to transition into other experience. So, for example, YOU has the You Made It Cafe right across from the train station. Youth can start there, but then they can go on to work in other places. They, just as one of many examples we have of that. So sometimes people say, well, is it really a systems problem and not about individuals who can't manage a home? I could go on and on about this. I'll just give you one example. When we were first trying to prevent discharge to homelessness, when we started doing work in this area, we only found 3 academic when we were talking to people who were homeless and say, what happened? As a nurse, I was embarrassed by the number of people who would say it was a discharge from hospital. I was discharged from hospital and I didn't have a place to go. And I'm thinking that, as a nurse, that offends me so deeply, that would be a journey, that would start a journey of homelessness. But I went to the literature to think, okay, well, what else does the literature say? We only found 3 papers on the topic that all declared it to be a myth. There was not a single paper in the literature on that point that actually said this is an issue. So I thought, well, this is weird. Why are they even talking about it if it's a myth? And meanwhile, I'm talking to people in London and I'm talking to people in other communities, other shelters, and they're all saying they see it, but the literature says it's a myth. So then I noticed there's this other London across the Atlantic. I don't know if you heard of it. So anyway, they had, one of the studies was from there, and it was from a hospital, and it was a really weird study because and it was sponsored by the hospital. So I'm thinking, well, that's weird. And the stated purpose was, what happens to psychiatric patients 6 months after discharge? But in the abstract and the conclusion, they're going on and on about not finding anyone homeless. Well, if that wasn't the question, why are you going on and on about it? And then plus, they lost 10% of their sample. So in 6 months. So on a hunch, given that the shelters were the ones complaining the loudest, I went to the shelter website in the other London, and glory be, the year before this came out, there was a position paper complaining about the number of psychiatric patients coming from that hospital. directly into homelessness. Who should I believe? I don't know. It's so hard. So then I looked at the other two papers. I couldn't find position papers, but they were also sponsored by hospitals. And in the year prior, both of those were in the States, there was a photograph of somebody being dropped off by ambulance at a homeless shelter. And so then they did this so-called study to prove that it wasn't really an issue. So as I say, when I started working in this area, it was not as obvious as it is now. But meanwhile, when you're talking to people on the front line, they had a very different story. But if you went to the academic, if I was basing it on the academic literature and not talking to frontline staff and not talking to people with lived experience, I would never have looked at it because the only evidence was it was a myth. So anyway, because of that, we got one paper out that we were able to figure out how many times in London this actually happened, that somebody was one night in a hospital, next year homeless. I can tell you the hospitals were not happy that I published that paper. But I said to them, I'm going to make you look good because we're going to solve this problem, and you can't solve a problem without identifying it. And even the press at the time, I made it really clear how brave we were in London to actually count it, given that nobody was counting it. Everybody else was, oh, no, we don't have that problem. So when we did the first pilot, it was we only looked, and we've done several, but just about the individual. So in that first pilot, we really kind of cherry picked. We were trying to think, what can we do? We had 37 different ideas. We ranked them from how easy would it be from 1 to 5. 1 was pretty easy, 5 was an act of God. Nothing got below 3.5. So then we looked at our 3.5s to come up with an intervention. And the intervention was to speed up the check from OW or ODSP to allow them to rent a place and to have a housing advocate help them. And so with that first study, we only included people who had no prior history of homelessness. They had stable income, either OW or ODSP, and it was a planned discharge. So the easy of the easy, right? The easy of the easy. No prior history. I was going to have 20 people on that site just to test if this would work. I had to stop at 14 because it was like studying penicillin and syphilis. We randomized. We literally, we had an envelope with the two things in. So it was completely random, which group, usual care or this extra help. Basically, I would call the boss at OW or ODSP and they would quickly do the check versus the social workers and the nurses trying like crazy and trying their darndest. So what happened, why it was like penicillin and syphilis, we stopped at 14, 7 in the intervention, 7 in the control. Everyone who got the intervention was fine. And in fact, 4 of the 7 got back to work because their mental health problem had been dealt with. They had no prior history of homelessness. They had stable income. They were in great shape. The people who got treatment as usual, 6 out of 7, even though it's only following for 6 months, 6 months were still homeless. They'd never been homeless in their life, and it was on the basis, essentially, as if it was a coin toss, who got homeless and who didn't. The 7th person for the study, I had to call a success. I don't think anyone would call it a success, but our outcome measure was housed. Never been in the sex trade before, had a very young child, and was recruited into the sex trade on the way into the family shelter. 6 months later, was still in the sex trade, which means her life expectancy is about 7 years, and she has a young child. But that wasn't an outcome measure in the sex trade, not in the sex trade. It's housed or not housed. That was actually statistically significant, even with 14 people. But I could not, in good conscience, randomize people in our further studies because it was so dramatic. I thought, if this group cannot be housed, cannot find housing in 6 months, who can? If you discharge them to homelessness, who can? Because that was like that was like the easy of the easy. It never occurred to me that they wouldn't. But that was literally a flip of the coin. So it had nothing to do with individual skills, motivation, anything. It was that they got the wrong toss. And we've got, I'm going to go quickly, we've done a whole bunch of stuff around preventing discharge to homelessness. We've moved from not only the psychiatric wards, medical wards, we've got a specialized youth version of it right now. So the thing is that homelessness can be addressed, but we need to understand it relates to policy in these spheres and not blame the individuals as the cause. And we have to have strategies that cross sectors, increase shares, decrease people, paying attention to transitions, and consider difference with subgroups. Different subgroups have very different needs. Like when I work with veterans, they say they don't go to the shelters because it's too loosey-goosey, there's no rules. When I talk to the youth, they don't go to the shelters because there's too many rules, right? So you have to look at specific subgroups for the different things. So then the other thing, just quickly, I didn't want it was not my plan to do this study during a pandemic, but things happen. So one of the big questions that always comes up, one, we never have good baselines when we look at these interventions because we don't really know how many people are homeless. And I know people in London have often said how frustrating it is when they keep hearing different numbers tossed around as to how many people really are homeless. And the reason it's really, really hard to figure it out because most of the methods for counting homelessness rely on people touching the homeless sector. And so if you don't do that, then you're really easy to be missed. But then when we have faulty numbers, we end up with the sector underfunded. So what we did is we did a national study, went to every province and territory twice during the pandemic. I got to say, one of those times it was probably very helpful to be a nurse because many of the territories, eastern provinces, we could only get in as essential visitors, which meant we had to apply to the public health at that level. Which fortunately they all agreed that homeless research was essential. And they did, because I didn't say I'm going in there to provide nursing, although they did sometimes say, well, you're here. And did try to poach my staff. They did poach a couple of my staff, I will say. But then we also, we're going 28 places. We can't be quarantined for 2 weeks. So then we also had to apply for another level of exemption not to be quarantined. Which meant usually a lot of testing. So my research coordinator, but the two of us went to pretty much every place. Then we had a third person, and we stopped counting once we hit 200 tests. And I'm not just talking about rapid tests. So I always say we gave up our nose for this study, noses. So one of the things we did on one of our earlier preventing discharge to homelessness projects is we developed an algorithm using health data because we knew if people were homeless or not. We were following them over time. And then we also worked with a group in Toronto that had a similar group where they knew if they're homeless. So we looked at the provincial health data and worked on an algorithm that could correctly identify them. So we thought, what if we could use this health approach rather than people touching the healthcare system, rather than touching the homeless sector. And it's not perfect because not everybody touches healthcare, but because people tend to be very sick when they're homeless, they often do. So basically, we found almost as many people in Ontario as what the federal numbers would suggest for the whole country. So and based on the percentage we know that don't touch healthcare, we could probably triple the current federal numbers, but still not perfect. So with this federal money, we're trying to look at how we could take it across, the country. These are all the places we went. Interviewed 400 people experiencing homelessness. We made a point of covering those rural and remote communities, and also had focus groups with a couple hundred people. I won't spend a lot of time, but I just want to point one thing out. The rural people do not count at all in the federal numbers because it's based on about 68 municipal areas that are larger urban centers. So one of the things we wanted to do is look at what happens by missing those rural areas. So I'll give you the Reader's Digest version. we know Indigenous peoples are always overrepresented in our homeless population, but look at the difference. Look at who is homeless in the rural areas. So by having, so this is really a systematic bias that by only including the urban areas in our homeless data. And people are in the rural areas are really in a tough spot because they don't have a homeless sector, therefore they have no data. Because they have no data, they can't get a homeless sector. And the other thing while we were out there, like we had just about 16% of the people had their first episode of homelessness during the pandemic. I don't have time to go into all of this. This was some of our focus group and qualitative data, but I just wanted to highlight this one because this was a surprise. NIMBYism, not in my backyard, has been around forever and is still a major problem. It's still the predominant problem. But one of the things I found that was encouraging is I saw more signs of yes in my backyard than I've ever seen. A lot of grassroots organizations where communities were really coming together and pulling together in a way that I have not seen in others. I have numerous examples from the communities that we visited. And I'd say, the next thing is just the homeless data sources. The most common way across the entire country that people count homelessness is a Microsoft Excel spreadsheet on someone's laptop that is not shareable with anyone. The other things that we'll see occasionally, the urban ones, are these point-in-time counts, by name lists, and HIFIS. And that's even why here in London you'll see 3 different numbers, because it depends which method you use. Okay? So what we did is, it worked out fantastic that we happened to have an algorithm during a pandemic. Because one of the things we were able to do, for example, was show that people with the algorithm were at higher risk of COVID. And I'm just showing you one slide from that paper, but it really moved the dial to getting people who were homeless prioritized. They were in English, this means they were about like 2.95, so about 3 times more likely to get a COVID test, about 3.5 times more likely to have an infection, 20 times more likely to end up in hospital from COVID. 20 times. ICU admissions 10 times, dead within 21 days of that first test, almost 6 times as likely as the general population. Within days of this paper coming out, one of the fastest papers we ever did, Ontario prioritized this population within the week. The group was prioritized across the country, but they had not been on the list. Which is why we wanted to do that paper. So it was very, very lucky we had that. This is just another example that just came out recently. And it was really cool because when I'm going around, I'm looking at the issues people are facing, and then we're going to the data to get evidence, right? So one of the things that I saw much greater neurodiversity than I have ever seen, including people with dementias on the street, people with Alzheimer's living with their family in a car during a pandemic. Can you imagine? And those are some of the people we interviewed. So we went to our provincial health data, but we also borrowed another algorithm looking at dementia. This study, as I say, just came out like last month or something. And basically, much higher risks. And again, I'll tell you this in English. What we did, we compared 3 groups. People who are homeless using our algorithm, people living in poverty, and the rest of the population. So if you look at the bottom line here, that someone experiencing homelessness was 70 to 90 times greater than low income and the general populations, respectively, to have a dementia. So how do we solve the dementia problem and ignore housing status? How often do we hear that? Like, how often do so many health problems, we don't look at housing status. And yet, if you don't look at housing status, you're missing something very important. Most often people were not looking at this with the homelessness, because you don't live very long when you're homeless. And this is an age-related illness. But what happens is you age faster. So very young people, younger than the usual guidelines were getting dementia, including Alzheimer's. And then this just came out like a couple weeks ago, April 25th. I also worked with CIHI, which is the federal data looking at data across the country, the hospital data, and if, again, looking at homelessness. If somebody was homeless, they come into hospital for any reason at all, you're going to be there twice as long, basically, is the short story for this one. And then opiate deaths. Has anyone heard about opiate deaths? With all that stuff about the opiate crisis, how often have you heard the housing crisis mentioned in the same breath, or homelessness mentioned in the same breath? So again, we were able to work with other people at another algorithm, and we brought in coroner data for this one. And so we were able to, and the first glance, just even looking on the coroner sheets, how often did they say the person was homeless? Again, this was pre-pandemic, because after that, all the data becomes a bit weird. 1 in 6, where it was actually written on the form that the person was homeless. But when we used our algorithm to look if they'd had a recent episode and looked at time, it went up to 1 in 3 opiate deaths. So how do you solve the opiate crisis and ignore housing status? The other thing that people were telling us so often when they used things like Narcan, it wasn't working because that's supposed to be kept at room temperature. 50% of the people that died that were homeless actually had someone with them, people who were trying to resuscitate them. People told us, which explains the finding, that if it was frozen, it didn't work. So how, when you're homeless, do you keep a drug that needs to be at room temperature? So anyway, takeaways. Sorry, I'm running a little bit late here. Homelessness was created by bad policy. That took a few years to really show up as being that bad. Solving homelessness requires policies to increase affordable housing and address poverty. That will, like, we have to increase the chairs and decrease the people circling. And there are lots of evidence-based ways for both of those things. They're not fast, they're not cheap, but they are out there, as I mentioned. Having more accurate numbers matters in order for us to show how expensive is it to allow home. Like, sure, it's expensive to have investment in public housing. How expensive is it when we have all these other health problems where somebody coming into hospitals there twice as long? It's one of those pay me now or pay me later scenarios. And finally, that homelessness is a health issue, and we cannot continue to discuss health issues and ignore housing. I'm just showing you proof. We went across the country, spent days in encampments, under bridges, along rivers. That's one of the Yes in My Backyard. That's ways in PEI that they got supplies to people. So thank you. And questions?
Ladies and gentlemen, Dr. Cheryl Forchuk. Thank you, Cheryl. Good evening, everyone. My name is Michelle Campbell. I'm President and CEO of St. Joseph's Healthcare Foundation. My job is to try and wrap up tonight's presentation, and it's really difficult to do that based on what we heard. As you might expect, we're pretty proud of the work that Cheryl and her team have done here at St. Joseph's and in our research program at Lawson. She's nationally recognized for the work that she's doing, and I remember hearing your sojourn across the country during pandemic and doing those interviews, and we were just awestruck that you were actually doing that during the most difficult time and difficult period in our country. But we're very fortunate to have Cheryl's leadership in this particular area, not just in our country, but here in our city. Because as you can see, homelessness is a very complex issue to consider, and we call it wicked for a reason. That's a term that really is applied to something that's very complex and very challenging and multifaceted. We have a strategy in London that is playing out, and St. Joseph's is playing a role in the health and homelessness whole of community response. We've been at the table since the very first coming together of the first 200 for the initial roundtable. We believe housing is a healthcare and a fundamental human right. And we've been at that table from the beginning and are playing a very substantial role particularly given our role that we believe we have as an ag organization in the community. And I'm going to call them out, and they're going to hate me for it, but there's 2 alumni of our foundation board, and I'm calling them out because I'm really proud of them, because they are 2 of a small group of people that stepped up to raise money for the homelessness initiative here in the city. They've worked exceptionally hard, and that's Peter Watmore and Murray Faulkner, who are here tonight. Thank you for being here. Very proud of the work you're doing. One of the hubs created through the initiative is now based on the grounds of Parkwood. It's an initiative that specifically supports Indigenous people who are experiencing homelessness. But I want to give you a few other statistics that I was given tonight to share with you. And numbers matter. We heard that from Cheryl. There are about 2,000 individuals living unhoused today in London, and this includes 600 with the most complex needs who are completely unsheltered, haven't slept under a roof in more than a year. Those are really sobering numbers. About a quarter of mental health care inpatients at St. Joseph's are considered homeless in hospital, and about 10% of high-intensity ambulatory patients identify as unhoused. We know there are significant unmet needs among chronically unhoused individuals for mental health care and addiction care. And it's one of the areas that we're very focused on at St. Joseph's and also within our foundation. You talked about transitions and how people sometimes get lost in the transitions. One of the transitions we know about, our staff know about in caring for this population is the transition in and out of hospital. We have people coming to us for care that come to us with no shoes. We learned last winter that almost none of our inpatients at our regional mental health care building, the Finch Family Medical Building, had a winter coat. And so for those of you who come to some of our other programming, we launched the Patient Assistance Fund for Mental Health at Breakfast of Champions this year. And the intention of that fund, and donors are generously supporting that, is our staff, when they see a need coming in or people going out back to community, and it could be something as simple as they need a bus ticket to get to a doctor's appointment. They need a gift card to go to the grocery store because when they go back to community, to their home, they have no groceries and they have no grocery money. It can be a winter coat. It can be something very, very simple like that. And so we now have a pot of money that we can draw on, that our staff can call on for whatever the need is in the moment for somebody that might need that help. The other thing that we're doing is our foundation has committed to putting a research coordinator at that homelessness table because what we heard from Cheryl tonight, and it's very true, is for the longest time, it was hard to deal with this issue because there was not enough data. We didn't know the scope of the problem. We didn't know how big it was. We didn't know the complexity of it necessarily. And so data is going to inform decision-making. And so we have actually, with the grateful support of a donor, have actually put a research coordinator at that table so that we can evaluate the efforts and keep checking in to make sure that our efforts are going to pay off. So those are some of the things that we're doing, and we couldn't do that without donor support through the foundation. So I want to thank you for being here tonight, for your interest, and to many of you who are so involved in this issue in our community and who help us to support that population in our mental health care program. Just a couple of closing notes. Again, acknowledge our corporate sponsor, Chartwell Retirement Residences, for partnering with us. They love this program and wanted to be sure that we could offer it again this year. We're going to be taking a break from DocTalks over the summer. And by the way, thank you for coming out on the evening of the summer solstice. And you came during a severe weather watch. We weren't sure you would. So that was good. And did you notice the sun came out just as you were coming in? So hopefully that'll continue on your way out as well. Our next lecture will be on September 12th with a lecture featuring Dr. Michael Silverman. He's the Chief of Infectious Diseases, and Dr. Jerry Burton. And they're, you're going to actually make me say this title. The title is, What Do Medicine, Fermented Foods, and Poop Have in Common? The Importance of Microbes in Human Health. Yes, and that's on camera, and I did say that. Anyway, it's going to be a very stimulating talk. Jeremy and Michael are very engaging researchers with a big story to share, so we hope you'll come back out for that. You can register online for all of the upcoming lectures on our website. So once again, ladies and gentlemen, thank you very much for coming. Thank you for your interest. Please stay if you want to have a moment with Dr. Forchuk. You don't need to rush off. And thank you again for coming.